All right, on to section 14. This is my last recording. I'm not sure if this is the last one you're watching. So, anyways, we did not do section 13 because that will be covered in a different semester with children and adolescents. So, we are just focusing on adults. Pregnancy, gestational diabetes, very important section because we need to take it very seriously because they have increased risk of developing type 2 diabetes later in life, as well as the children that they have an increased risk of diabetes type 2. And I'm not going to go through every single slide in detail, but this is the obvious preconception counseling. If someone's already diabetic, they're going to have to make a plan about when they become diabetic, and just they should understand all the complications, which it says right here. So they should probably go to a high-risk OB, which usually they would be sent to that. But I want to talk about things that we need to think about in primary care, which would be, do you have a history of gestational diabetes? If you're getting a history, if they're obese and have HDLs that are low, right away I'd think, okay, let's do a history. Do you have a history of gestational diabetes? If they do, well, geez, you're at really increased risk, and maybe they have a high triglycerides, so they have metabolic syndrome now. So now you have to go down that road. So what it says is, due to the increased red blood cell turnover, the A1C is slightly normal and lower in normal pregnancy than it is in normal non-pregnant women, so it's slightly lower. The ideal A1C target in pregnancy is less than 6, if this can be achieved without significant hypoglycemia. It can be relaxed to less than 7, but we don't want babies that have macrosomia, that are born, that are overweight or have any issues. So these are the glucose targets. In order to diagnose diabetes with type 2, we went over that already, but remember, it's that oral glucose tolerance test. But these are the glucose targets. Their fasting should be less than 95, or a 1 hour postprandial less than 140, or a 2 hour postprandial less than 120. So after they should be checking them at home. Lifestyle changes is important. They should go see a diabetic educator, and they put them on a specific diet. It's most likely carb counting. So you can have 15 carbs at lunch, which is 1 serving. You can have 30, which is 2 servings at dinner. This is just an example. Insulin's the preferred medication in gestational diabetes because it does not cross the placenta. Metformin and glyburide should not be used as first-line agents in pregnancy. These cross the placenta, and metformin, if they're on it already for PCOS, then it should be discontinued once they find out they are pregnant. So the main thing is insulin's the preferred management for both type 1 and type 2 diabetes in pregnancy. Women with type 1 or type 2 should be prescribed low-dose aspirin, usually 81 milligrams from the end of the first trimester until the baby's born. These people are going to be an OB, and so that will be most likely up to the OB, but if you will see pregnant women if you're working in family practice, so this is really important to know. And in pregnancy, those patients with diabetes, chronic hypertension, sorry about the noise, their blood pressure should be really well controlled, and they should not, and another thing, we should be careful about what medications we're putting them on. No ACE inhibitors, no ARBs, no statins. They should be avoided in sexually active women of childbearing age who are not using reliable contraception. So that's something that you should think about, even if they're not gestational diabetic, when you have somebody with a diabetes. And we're seeing more diabetes type 2 in younger people. So it's not necessarily something you are diagnosed with age 50. Yes, we have an average, but we're starting to see them when they're even kids and teenagers. And that is it. And I appreciate you listening to all these slides. I know it's lengthy. Diabetes is very complicated. If you have any questions, please, you can email me at Jennie, JENNIE, .peters, PETERS, @marquette.edu. Thank you.